how we contextualize a very broad topic to what are the key issues in primary care around diabetes management. So before you start, let me just make sure we are okay. Okay, ready to go? Amma and Luca. Luca, I think you are co-host. And
yes, so I'll be starting. Can we get the presentation up, or how do we do this?
You just, if you hover over the screen, you'll find green share screen, click on it. And unless you want me to give you the presentation. I'll just open it for you quickly. So you've actually put a password to it. Amma, you've put a password to it. I didn't realize it. So you'll have to open it yourself.
Hi. No, sorry. The password is just for editing, so you can actually still open it.
Well, it doesn't allow me. So what is the password that you put in?
Oh, okay. I'll send it to you, but I am trying to share it.
Oh, it's okay. I think it was read only. I've got the read only.
Yeah.
It's fine. Let me just quickly share it for you so you can get going. I'll move it so you can move along. Okay, there you have it. We can start. Just tell me next and we'll move. Go ahead.
Okay, cool. So yeah, this is just an introduction and into diabetes in primary healthcare. Yeah, so Prof, you can go to the next two slides, really. So that's the overview, the main topics that we'll be discussing, and then yeah, I'll start off with essentially what is diabetes. So as mentioned, we're just going to give a bit of a background of knowledge that hopefully all of us know by now already. So diabetes is a metabolic disorder of various etiologies, resulting in a chronic state of hypoglycemia with resultant disturbances in carbohydrates, fat and protein metabolism, either due to insulin deficiency or insulin resistance or both. And the reason why it's so important for us to have this condition under control is because it leads to long-term complications such as that involve microvascular and macrovascular origins, as well as neuropathy. I also just included a picture of lock and key there, just because, I mean, look, this definition that I provide to you is one that's very, very easy for us to, as doctors in the medical world, to understand. But it's not something that you should necessarily or would be advised to necessarily to put back to your patient in the primary care setting, especially for those who don't have a medical background or wouldn't know all these terms and might arguably be overwhelmed with some of these terminologies. So just a simple explanation, you know, your body is made out of 1,000,000,001 cells, all responsible for doing their job to keep you alive and function as a human being. Those cells need energy. You ingest food, it's absorbed into your bloodstream as sugar. Insulin is the key that opens those cells to absorb the sugar. And without insulin, you can understand why your sugar levels are high when detected in your HCT or through your blood tests. And obviously, without the energy, you can't to supply your cells with in the form of sugar. You can't really be functioning that adequately, or as a result, you will get sick and those other complications that we can then delve into further. So just next slide, please. So again, diabetes, as mentioned, as a result of insulin deficiency or resistance or both. But as mentioned also, it is as a result of various etiologies. So this is the etiological classification of it. And this is not to overwhelm everyone, but it's more to give people just understand or more of like a heads up that, you know, not everyone that walks in the primary care health setting is going to be a type 1 or type 2 diabetic. Now, granted, your type 2 diabetic accounts for about 85 to 90% of patients entering the primary healthcare setting, with type 1 being about 5 to 10%. But it is also encouraged that through your history taking that you pick up on the other possible causes and then make the relevant referrals to the facilities that will further work them up and then come to the definitive diagnosis. Just next slide, please. And so for our purposes, we'll be focusing mostly on type 1 and type 2 diabetics or diabetes mellitus. So when these patients come through our doors, it's important to have a good idea as to what you're looking at and what is likely going to be the phenotype or how these patients rather present to us. So your type 1s are usually younger patients, whereas type 2 are predominantly older patients with a host of comorbidities attached to them. Furthermore, the type 1 patients are usually lean, whereas the type 2 patients are of a much have a much elevated BMI. They also type 1s tend to present in an acute onset of their symptoms, symptoms being polyuria, polydipsia, visual disturbances, etc. Whereas your type 2 are often asymptomatic and they have a more gradual onset of their symptoms. The type 1 diabetes often produced with ketoacidosis at a point of diagnosis, whereas type 2s, they can, but it's not necessarily a defining characteristic when making that diagnosis. And then very importantly, type 1 diabetics, they require insulin for survival and as part of their management, whereas type 2s, we generally start them off with lifestyle changes and then eventually initiate them on oral agents. And eventually, if they are still not managed with those interventions, they may progress to the need for insulin. And then, as mentioned earlier, type 1s usually come in young, not really with any comorbidities, if none at all, whereas your type 2, they have a host of comorbidities attached to them. Next slide, please. And then this also is just to give you a heads up that sometimes, granted, I've provided the table now of what you can expect to look out for your type 1 and type 2s, but they don't always present that way to us. And but then again, this is to account for the 2 to 5% of your diabetic patients that come to you. So we have MODY, or the mature onset diabetes in the young. They represent a group of autosomal dominant single gene disorders resulting in impaired insulin secretion. And so the onset of diabetes in adolescence or early adulthood, whereas we usually expect these ones to have a type 2 diabetic phenotype. They don't really have that, and they also, as a result, have mild or no symptoms. Remember, the type 1s usually have the symptoms present that really point us to a direction that they are hyperglycemic. These groups don't tend to have that, and they usually have a strong family history of early onset diabetes, usually younger than 25 years old. And then another group also that tends to be quite a popular one is the latent autoimmune diabetes of adulthood. It is a form of type 1 diabetes that's often confused for type 2. And this is just characterized by a slower autoimmune destruction of the beta cells, and thus results in a slower onset of hyperglycemia. Typically, these patients are older than your traditional type 1 diabetics who often present in their teens, and they are not obese, because generally when you think of like those who present with hyperglycemic disorders at an older age, you think they'd be accompanied with classic metabolic syndrome, the increased waist circumference, raised BMI. This group unfortunately does not have that. So it may throw you off in the beginning, but it's just to let you know that should you come up with something a bit odd, best to refer, and so that the further management can be, or further workup can be done. Then, oh yes, thanks. And then we move on to diagnosis. So diagnosis of diabetes, we basically split them up into two categories. It's those who present with symptoms of hyperglycemia and those who present without symptoms of hyperglycemia. For the patients who present with symptoms of hyperglycemia, i.e. Polyuria, polydipsia, blurred vision, or weight loss, or metabolic decompensation, so the diabetic ketoacidosis, or formerly known as HONC or HSS, you only need a single test to confirm this diagnosis, and these tests are one of four. So it's random glucose that is more than 11, fasting glucose that is 7 or more, an HbA1c of 6.5, and a 2-hour post-loading glucose of more than 11. And then for those without symptoms, unfortunately, you need tests within, you need tests within the 2-week period to be taken on separate days. So you need 2 tests that both fulfill these criteria, within a 2-week period on separate days to then make that diagnosis. And again, it's fasting glucose of more than 7 or more, 2-hour post-loading glucose of 11 or more, and HbA1c of 6.5. It should also be noted that your HbA1c of 6.5 is recommended as the cutoff for diagnosing diabetes, but a value of 6.5 does not exclude diabetes if your other glucose test is pointing to the patient possibly having diabetes or falls to criteria as stated above. Also, there's also we'll come to it, but there's also a concept of called impaired fasting glucose and impaired glucose tolerant. And these are categories of intermediate hyperglycemia that can be identified in patients and what's important about them is that it gives us an opportunity to try and, initiate a form of lifestyle changes so that patients can get on top of it, because at the end of the day, these are one of the risk factors that put patients at further risk of developing diabetes in the future. Just next slide, please. So yes, as mentioned, all right. So this is the clinical progression of glycemia disorders. Regardless of the etiology of what causes you to end up having diabetes, these patients all follow this progression. So at one point, the glucose is normal, and slowly or fast or quick enough, it reduces to impaired glucose tolerance or impaired fasting glucose, and then eventually to diabetes mellitus. So again, it's these are just ranges that for you to be aware of, especially when you come across patients with the fasting glucose of between 6.1 to 6.9. It's a good opportunity for you to use that as a screening tool and then act upon it by counseling your patients and start initiating lifestyle changes where necessary. As well as if you are to perform a 2-hourly post-OGTDs of 7.8 to 11, just to be cognizant that just because it's less than 11 doesn't mean, okay, no, patient's fine, go ahead on your merry way. These are things that should be, brought to the patient's attention, and then the correct steps should be taken to initiate some form of lifestyle modification. Just the next slide, please. And then with regards to screening, so we included a slide of screening for type 2 diabetics because these are patients who come with a slower onset of the state of hyperglycemia, and generally it's patients who have multiple risk factors that can be modified before they reach that endpoint of being diagnosed with diabetes. So we have we can separate them into high risk and low risk individuals. Your high risk individuals are all your adults who are overweight, so raised BMI, and with those those who are overweight plus one or more of the listed factors. Again, if you pick up from a good history, you can maybe detect that maybe some patients have a history of physical inactivity. As mentioned, especially with type 2 diabetics, they are really mostly accompanied with a host of other comorbidities. So it's good to be aware of that, especially with your patients who are known hypertensives, known with PCOS, known with dyslipidemia. Again, from a history taking, you can detect if patients have any relatives, especially first-degree relatives with diabetes, cardiovascular diseases, those with gestational diabetes or macrosomic babies, previous IFG and IGT as mentioned earlier, and then any conditions associated with insulin resistance, like if you detect severe obesity and acanthosis nigricans. It should also be noted that the OGTT is the preferred test in high-risk individuals. So when you're screening these patients, you can screen them every 3 years according to the 7 DSA intervals if those results are, if all the results are normal. You can screen them every 3 years, but based on, as we mentioned earlier, these are just guidelines, and if you feel like the initial results put them at risk, you can screen them more often to annually to 3 monthly as you clinically deem appropriate. That's it from my side.
Okay, so for treatment options in diabetes, just for time's sake, we'll only go into treatment for type 1 and type 2 diabetics. So for type 1 diabetics, as we mentioned, they don't start on oral agents, they require insulin. And there are multiple options for the insulin treatment. However, the preferable treatment option that is more commonly used is the basal bolus insulin. So this entails pre-meal short-acting insulin. So before each meal, they inject, as well as a bedtime intermediate-acting insulin. So they'll just inject before bedtime just to keep them going over the night. Yeah, you can go to the next slide. Oh, sorry, next slide, please. Thank you. So for type 2 diabetics, they have a much wider range of treatment options. So we initially like to start with lifestyle changes. So that includes things like dietary advice, as well as advice on physical activity. So things such as 30 minutes of exercise at least 5 times a week. However, if lifestyle changes don't help, then that's when you like to start patients on oral agents. So the initial agent is usually metformin. However, if that still doesn't work, then you can start them on the sulfonylureas. So what's quite common here is glimepiride. And then after that, if that still doesn't work, then you can start patients on basal insulin, which is also known as Protophane, well, the brand name. And then you can also start them on biphasic insulin, or the pre-mixed insulin. And then finally, there's also the option of basal bolus insulin in type 2 diabetics. However, that isn't commonly used in type 2 diabetics, but it can be used. Often the insulin indications for type 2 diabetics is usually when patients are unable to control on oral agents, if there's a temporary use for major stresses such as in surgery or medical illnesses, and if patients have severe kidney or liver disease or in pregnancy. So just this is a table, or 3 tables just summarizing how you usually move patients, type 2 diabetics, for treatment. So step 1 is usually they're diagnosed as type 2 diabetics, and that's when they undergo lifestyle modification with or without metformin initiation. And you can assess the patient on a weekly or monthly basis, depending on you as the clinician, and you aim for the targets that's listed on the table. If, however, you're unable to reach these targets, then the patient has basically failed step 1. So you can then go on to step 2, which is adding on a sulfonylurea. And once again, you continue to assess them and you aim for the targets. If they still are unable to reach the targets on the sulfonylurea addition, then you go on to step 3, and that's when you add in an intermediate to long-acting insulin, or you can go with substitution therapy, which would be the use of biphasic insulin. At this point, if you do go on to step 3, then it's usually best to stop the sulfonylureas for the patient. Yes, you can go into the next slide. Thank you. So for the treatment adjustments, I won't go into all of it into detail. You can just read it on the slides. But basically, an example for the oral agents is that, so for metformin, you can usually start patients on 500 milligrams daily, or BD. They can take it with meals, and then you adjust it based on their fasting glucose levels or their random glucose levels if they do come to the clinics, because often it's not actually fasting. So you can increase that to a maximum of 850 milligrams TDS, and then it's important to also monitor the patient's renal function. So if their GFR then drops below 30, then it's important that you stop metformin. And so you titrate the levels based on the glucose levels. And then obviously, if the patient isn't able to achieve glycemic control, then that's when you can start adding on other agents. Next slide, please. Thank you. So for insulin dose adjustments, so for this one, it depends on the insulin therapy that the patient is receiving. So if you are starting the patient on basal insulin, so that means they'll only be taking the insulin at night, you can start them off at around 0.3 units per kg per day, or at 10 units daily, in the evening before bedtime. If that starting dose isn't effective, you can increase it by 2 to 4 units per dose every week, or how often you are following up on the patient until you achieve glycemic control. But obviously, if that doesn't help, then you can switch on to biphasic insulin, which is also known as the substitution therapy. So what we usually use is ActiRapid, That's the most common one. So patients will be injecting in the morning and at night. So for accurate, in order to calculate the daily dose of insulin, so you also use 0.3 units per kg per day for the total daily dose. Then you divide it accordingly. So in the morning, you divide the total dose 2/3 in the morning, and then 1/3 is at night. And then you can change the dosing of the medication after that based on the patient's morning glucoses and night glucoses. Finally, if you do start patients on basal bolus, even though it isn't common, you basically use the same method as that in type 1 diabetics. So you start them on about 0.6 units per kg, and you divide that total dose into 50%. 50% of that dose is used as the basal dose, and then the other 50%, you'll divide it into 3 equal doses, and those are the pre-meal injections that the patient uses. Next slide, please. Thank you. So in primary health care, it's quite important to continue monitoring the patients who are diabetics. So for those who are, well, all patients ideally would like to have glucose monitoring at home, but it's especially important for those who are on insulin. So they do need glucose monitoring, and dependent on which insulin regimen they are on, that'll also determine how many times they need to monitor themselves. So for example, if patients are on the basal bolus regimen, then they need to monitor at least 3 to 4 times daily. Then at every single visit, it's important to do a blood pressure, finger prick glucose, and then hypothetically, it would be nice to do BMI and waist circumferences at the clinic every visit, but I know that doesn't always happen. Then it's also important to ask patients about symptoms that they experience, especially for things such as diabetic neuropathy. So looking for signs like sensory loss, unsteadiness on their feet, any peripheral pain that they're experiencing, or erectile dysfunction, because this could also help you indicate how controlled their sugars are. Then every year, patients also need to be screened for diabetic retinopathy. So they need a yearly eye test. And then they also need a yearly official foot exam just to check for diabetic foot. HbA1cs can be checked dependent on the patient's control. So patients who are well controlled, they need to have a HbA1c monitored every 6 months, but those who are uncontrolled need a 3-monthly HbA1c. And then you can also do a urine dipstick just to look for any proteins which can help you assess if there's any renal dysfunction occurring in patients. And finally, patients also need a creatinine, a GFR, and cholesterol at baseline, so as soon as they're diagnosed, and as well as yearly, so you can compare and assess renal function as well as control other risk factors. So the targets that you're looking for when assessing patients at every visit, so when you do check the HbA1c, you want to look at 3 different categories. So for patients who are young, low-risk patients, newly diagnosed, and they don't have any history of cardiovascular disease, a HbA1c of less than 6.5 is what you're aiming for, as well as postprandial glucoses of less than 7.8. However, a majority of patients don't actually fall into this category. So if they have a HbA1c of less than 7, that's still considered acceptable, and a postprandial glucose of between 5 to 10 is also considered acceptable. It's important, though, to take note of patients who are elderly and patients who have severe target organ damage or a poor short-term prognosis. So for these patients, you need to consider or weigh in the risk of the patient becoming hypoglycemic versus you actually reducing the micro and macrovascular complications that they could get. So for them, if they do have a HbA1c of 7.5 or postprandial glucoses of less than 12, that can also be considered acceptable. Next slide, please. So this is just an example of a diabetic diary that patients can keep when they're monitoring their glucose levels. So basically in the morning, they check their sugars, and then, just depends on how often they are injecting. So at every visit, patient education is also very important, as that's often one of the few times that you'll actually be able to provide health promotion to patients. So as said before, you can advise them on dietary and changes as well as physical exercise, their HGT monitoring, which is very important, foot education, as well as injection technique. So that would be things like alternating sites for injecting, 90-degree angle when injecting, and then safe needle disposal. You're also, it's important to also educate them on the warning signs, which we'll go into later. So next slide, please. So this is just an example of a diabetic foot table that you can use, but it also just helps you to remember what to look for when patients present. And then advice that you give them around correct cleaning and drying of feet, checking the feet daily, and using correct footwear, stuff like that. Next slide, please. Thank you. So emergencies, I won't go into in detail, but it is important to just be able to recognize the emergencies in the primary healthcare setting so that you can refer patients accordingly. So for patients who present with simple hypoglycemia, these patients are usually very stable. They've got stable vital signs. They're awake, alert, and orientated, and they don't have any signs of DKA or HHS. So these patients don't necessarily need to be referred to a secondary or tertiary institution. You can just rehydrate them, give them Actia Rapid, and then repeat the HGT in 30 minutes to an hour to see if it has come down. If it has, then they can go home. Next slide, please. Thank you. So DKA, this one, patients usually present drowsy or confused. They can have a history of nausea and vomiting or polyuria and polydipsia, as well as an increased respiratory rate and abdominal pain. So it's usually more acute in these patients. And you'll also note that they have a hypoglycemic that can be about like over 13. If you test their urine, there'll be ketones in the urine. So you'll have to have a high suspicion of DKA. These patients, you also need to rehydrate and provide Actia Rapid. And then it's important to refer them to a secondary or tertiary institution for further management. Next slide, please. Thank you. This is with patients who have HHS. So this is usually middle-aged to elderly patients who have high mortality rates. And it's often precipitated by an infection or something else like a myocardial infarction or a stroke. So they present quite similarly to DKA. They can also present with coma, but they also often have severe dehydration. In these patients, they've got marked hypoglycemia. So when DKA could have been above 13, 14, these patients, usually it's above 30. It can go as high as 50, even hypoglycemia. And ketones may or may not be present in the urine. So if this does happen, then you have high suspicion of HHS. The initial management is similar to that of DKA. So you also need to rehydrate them, give them 10 units of Actia Rapid, and refer them to a tertiary institution, which is very important for their management. Finally, hypoglycemia in patients. So these patients, they usually come in, they can have tremors, sweating, tachycardia, dizziness, impaired concentration or confusion, as well as seizures. So their management will depend on whether the patient is conscious or unconscious. So conscious patients, you can still give them an oral sugar solution to help them and then recheck their HGTs. However, if they are unconscious, then they need an IV line, and you need to give them 50 mL of 50% dextrose water stat and reassess the patient. Then once their sugars are increased, you just maintain them with 5% dextrose water until their HGT is stabilized. So you need to just watch out for patients who are elderly, malnourished, and very ill, or have long-standing diabetes, as well as patients who maybe have presented with a previous alcohol binge, as those can present with hypoglycemia. And then in terms of referral for hypoglycemics, those who you need to refer are all patients who are on oral agents, hypoglycemics who do not recover, all children who present with hypoglycemic episodes, and then if you are unable to find an underlying cause for the hypoglycemia, then you can refer them. So that's it. So yeah, those are the links for just the three at the bottom are the links for the extra articles that we found.
Thank you very much. Good.
Yeah.
Any questions or any comments from the family physicians? Anything that would like to be added? Okay, while we're waiting, I think some of the things that are very important in primary care, I think that has been mentioned, I just want to emphasize again, is the question of lifestyle management. We often rush to treat without addressing that, or in our treatment ignore that and say, well, that's not something we can deal with. We just do the sort of courtesies of talking of diet and exercise. If you really want to make a difference to the diabetes, please get community health workers involved and explore the ability of community health workers to sit with patients or visit them at home. So I think that's an important thing, and understand that biopsychosocial is really not just talk. The psychosocial issues are very material. Again, community health workers can be part of that. Draw on them, don't just ignore them. Try and think those issues through and address them. I think the other is that you mentioned that treating an elderly patient with over vigorously is some challenge. So please don't try to push to get below 7 on HbA1cs. Above 8, 8.5, you're pretty reasonable with your HbA1c. We see a lot of young doctors calling patients back every month, every second month. There's a program in place which is there for diabetes. You should be looking at it, which is that you can get the patient to have medicines delivered if the management of their diabetes looks reasonable. And that can be in these ranges under 8.5, that you can get them to the CCMDD program and get the medicine delivered to them every 2 months. Many a time for you to bring them to the facility to sit for an entire day, the whole management gets messed up because they're often fasting when you get the wrong results, or the machines are badly done, or the patient's stressed. So there are a number of issues that complicate it. Doing an HbA1c is far better than a dipstick. So that diary that was mentioned, I'm not a big fan of it because it's actually challenging. It's very useful in the beginning for patients to understand how they feel when their sugar is at various levels, and to give them a glucometer and say, map it out so you know what a preprandial and a 2-hour postprandial blood glucose looks like, feels like, and how you experience it, so that they pick up what hyperglycemia and hypoglycemia means. So you get that kind of patient familiarity. So consider that. But after that, I would strongly advise move to HbA1cs to consider that as the option to work with. Any other comments from anybody else? I don't want to hog the conversation. Anyone else would like to raise any issues? Maggie?
Just
Yes, go ahead, Maggie.
say that patients with diabetes need to be educated in many different aspects,
Yes.
and don't miss the opportunity when you diagnose a patient with diabetes to start educating. Don't throw to the patient everything at once, but start using every consultation an opportunity to give the right education and to empower the patient. Uh, a lot of patients come with uncontrolled diabetes, not just because they don't want to be controlled. They don't know how to do it. They don't know what is the right dietary requirements. And then the other side, it's us who are just keen to prescribe the medication without even looking how controlled is the patient. And most of our patients are uncontrolled, and some of them don't require oral medication. They require treatment with this insulin, and that gets delayed with years and years, and until patients develop retinopathy and nephropathy with the complications of diabetes. So keep in your minds that thing. Thank you.
Thanks, Maggie. Very important. So I think don't forget the annual visit, which is really important and should be focused on. But other than that, quarterly visits with your HbA1c, and then managing that very deliberately, not just to repeat. And it's a whole lot better than carrying patients to come every month and trying to only manage through a glucose HDT. Not a good way to deal with it. HbA1c, and you can even shift that to 3-4 monthly, but at least you're managing the HbA1c in a much more deliberate fashion. And then you can be much more aggressive because you know what you're dealing with rather than just an oddball blood sugar that could be badly done. So please move your treatment management away. One of the biggest challenges I have is patients are, whenever we have a consultation, if I come along, I invariably will ask, why is this patient having blood sugars that are badly controlled? You ask their diet and they'll tell you, no, I love my pup, but I don't eat anything sweet. So we need to understand that diabetes is about glucose. Glucose is a lot in all of our starches. Ask your patient, what are the starches like that they're eating? And invariably, they're eating lots of starch. And they don't appreciate that they've got to cut back on starch or look at healthy starches like vegetables, etc. So a lot of people eat pop and they come to it 3 times a day and their sugars are out of control. You need to educate them about their starches. So focus on that. Any other comments? I think, Bali, you want to say something? Go ahead. You're unmuted. Are you okay? Right. Okay, I think we're on the hour. So if there are no other comments, anybody else? Dr. Manda, I don't know whether he's left, but I think if there are no other comments, we can close now. Thank you all very much. See you next week. The case is going to be circulated. This will be on the website.